Thanks a lot for having me. Well, yeah, as Nora said, we actually just opened a travel and tropical medicine clinic at Stanford. It was a long time coming. We've been trying to open one for years, and it just opened 3 weeks ago. So please come to our clinic, tell everybody about it. And it's always been an interest of mine throughout my career, travel medicine and especially tropical medicine. So I'm going to kind of go over the key things that we do in a travel clinic, both to show what a clinic like ours does, and also just to answer sort of specifically maybe for people who are traveling to certain itineraries, what kind of things to be thinking about. And the main things that we think about in a travel clinic are, as you can see here, malaria prophylaxis, various certain immunizations, and traveler's diarrhea. And then we also do a lot of counseling about various infections that are less common or don't have immunizations as well. So why do we have travel clinics and what's happening with this field? It's really a burgeoning field. In the last 20 to 30 years, it's gone from being not really a specialty at all to having its own certification and practitioners and practice guidelines. And that's because so many people are traveling. As I'm sure you all know, we live in a global world now where almost 1 billion people cross international borders every year, with a minority of them, but a significant minority, going from the developed to the developing world, which is most of us here, the kind of people that we think about going to travel clinics. And actually, unfortunately, only a minority of people actually do go to travel clinics before they travel, only 35 to 60%, depending on the series. And only a very small minority overall go to an actual travel clinic. Most people go to their primary care doctors, which is fine. But for more complicated patients or more complicated itineraries, it's nice to have the expertise of people that do this every day and have a lot of experience with more complicated types of questions. Anyway, so of people who travel, actually, as you can see, a lot of people do get something. They get some kind of self-reported problem, be it a rash, diarrhea, fever, up to more than half of patients in some studies, or up a quarter in others. And at least 10 to 20% of them are sick enough that they actually seek medical care post-travel. So that's why pre-travel medicine is important, because a lot of people travel and a lot of people get sick, especially if they don't visit travel clinics. And then I want to just talk for 1 minute about something we now refer to almost as its own demographic, a VFR traveler, if you will, or visiting friends and relatives travelers. Visiting friends and relatives travelers refers to people who are born in developing countries, have moved to the U.S., and then are going back home to visit friends and relatives, or the children or first-degree relatives of those patients who maybe were born in the U.S. but have a very strong connection overseas and are going, again, to visit friends and relatives. So there's a lot of studies emerging in the last 10, 20 years on this demographic of patients, and it's well known that they seek pre-travel care less often. They tend to get sick more often, and they tend to get sick with more risky diseases more often. So here's a great study, for example, from about 5 years ago, which showed that among immigrant VFRs, which is born overseas and moved to the U.S., in this column, traveler VFRs, which is usually the children of such patients, and then regular tourist travelers, people born in the U.S. Who are just traveling for tourism. So immigrant VFRs visited travel clinics only 16% of the time out of this case series, whereas tourist travelers, so 60% of the time. So that's something that our primary care colleagues, we always are telling them to identify people who are about to travel and get them into travel clinics or get them advice. And this is a big part of the reason why VFR travelers get sick more often, because they don't take malaria prophylaxis, they don't get immunizations, they don't seek advice and think about the things that make travelers sick. And of those who got sick, immigrant VFRs had to be hospitalized a third of the time, whereas only 6% of tourists that got sick had to be hospitalized. So that's a big difference. And if you take the specific example of malaria, which is probably maybe the single most important infectious disease among travelers, so this is of patients who had got sick and had a fever who had been to Africa. So this is just one example. But of that group, immigrant VFRs had malaria 45% of the time. 45% of febrile immigrant VFRs had malaria. And of febrile regular tourist travelers, only 9% had malaria. So this group seemed to be doing something that was more risky, like maybe going to areas where there's more malaria, or maybe they're just not using malaria prophylaxis or sleeping under beds or whatever it is. So anyway, as travel medicine providers and also as infectious disease specialists treating post-travel sick patients, we think about this. We think about the fact that a VFR traveler is at higher risk for a bad thing. If they've got a fever, we're more worried about them. And we also think about it pre-travel. We really try to get those patients in the clinic and give them advice and appropriate prophylaxis and immunizations. So I'll kind of go now into what we do in travel clinics. So the first thing is, one reason to go to a travel clinic is that we always go through a lot of general advice. In our clinic, we give a long handout with all kinds of advice that has this in written form. And we talk about it too. So we talk about general things that basically seem like common sense. But because we talk about it right before a trip, I think it does help a lot with patients remembering to follow a lot of this advice. One of the most important things is avoiding insects. So sometimes people think, for example, that, oh, I'm taking malaria prophylaxis, I'm taking a medicine to prevent malaria, so I don't need to worry about it. I can get bitten by mosquitoes. But first of all, any medicine is not 100% effective. Any malaria prophylaxis can fail. But also, there's a lot of other things transmitted by mosquitoes or by ticks, like dengue fever or tick-borne fever in Africa or tick-borne encephalitis. So wearing appropriate amounts of DEET, we usually recommend 30 to 50% formulations of DEET during mosquito times. Sleeping under bed nets, wearing appropriate clothing to protect yourself from getting bitten is important to do. And maybe more than anything else, maybe more than any medicine anybody takes or immunization you might get, protects you against serious illness. Safe food and water practices also seems like common sense. And people sometimes think, oh, I got vaccinated against typhoid, for example, which is a food and waterborne illness. But again, the typhoid vaccine is not perfect. In fact, it's a long way from perfect. So, drinking bottled water and not tap water, or treating your tap water, boiling it, is important. Eating things that you can peel, or hot piping food, and not salads that have, that are in places that you might be having risky food. Those things are so critical because traveler's diarrhea is so common, and there are more serious things than traveler's diarrhea, like hepatitis or typhoid, that you can get from this. So that's a really important thing we always go over. Freshwater swimming is a smaller one, but there's a couple of diseases I'm going to mention very briefly later called Schistosomiasis and Leptospirosis that you can get from swimming in lakes and rivers and streams in certain parts of the world. And safe behavior, that sounds like so general, but it's also very important because so there's a lot of components to that. Not putting yourself in places where you're at risk to get mugged, or not going to places where there's a lot of civil unrest. But something as simple as traffic accidents. We spend all of our time thinking about malaria and immunizations and medicines for diarrhea, but the most likely reason someone's going to get seriously injured or die, if that's going to happen, God forbid, to a traveler, is that they're going to get in a car accident because people don't wear seatbelts, or they're riding on the back of some crazy motorcycle in Phnom Penh or whatever it is. They tend to be more risky about motor vehicles when abroad than here. So those are things we try to remind people too. And the last general thing is travelers to high altitude. We counsel them about slow ascent and whether they might need medicines to prevent illnesses for that specific group. And then lastly, on the general advice front, despite all of the efforts of travel clinics and the burgeoning field of travel medicine, still only about half of patients, or 2/3 at most, take the malaria prophylaxis when it's prescribed appropriately. So the most common reason people get malaria who are on prophylaxis is not that the prophylaxis failed, but that they didn't take the prophylaxis appropriately. So that's something we always try to spend a lot of time reminding patients during our clinic. And again, despite the counseling on food and water, it's just so hard to do or so tempting, but 90% of travelers drink or eat unsafely at least once or twice within several days of arrival in an at-risk area. So those are numbers that explain why illnesses are so common after or in association with travel. Okay, so I'm going to move into some of the specific medical things we look at, starting with malaria. There's some really good resources available for free online like this. This is the CDC Yellow Book. And CDC has an entire website with multiple links and all kinds of stuff. If you go to their main page, then they have a link called Travel. And then from that, you can access all this information. The most important single one is the Yellow Book, which is updated every other year and goes through all of the recommendations on immunizations, malaria, traveler's diarrhea, general stuff. We use it a lot in our travel clinic, and it's a great starting point I think for anybody, including the layperson, to look at yourself. Another nice thing about the CDC website, this is an example of a traveler to Uganda. So it shows you travel notices, so maybe outbreaks or something going on wherever you're going. Goes through the vaccines, malaria prophylaxis like down here, all kinds of good information. Another great resource that we use, so this is something we subscribe to in our clinic and we pay for, is Travax. So this is where we generate this great printout that we give to patients, and we look through ourselves, and we can generate these really detailed, not just country level, but provincial level maps for where exactly is malaria or yellow fever, what are the recommendations. It's kind of a second source in addition to CDC that we use. So let's start with malaria. Malaria is probably the most important of the infections we're going to talk about. It's the most common and most deadly parasitic, or I should say it's the most deadly parasitic infection in the world. It's caused by 5 species of this genus of protozoans called Plasmodia. The names of them are up here. The most important one, though, by far, is Plasmodium falciparum. That's the species that causes almost all of the deaths due to malaria and most of the morbidity or disease due to malaria in the world. Malaria, as you may know, is transmitted by mosquitoes. And the mosquitoes that transmit malaria predominate in rural areas. So there's usually more malaria in the countryside than in cities. And they're also night-biting mosquitoes. So sleeping under bed nets usually is pretty good at protecting against malaria. The other thing about P. falciparum, I mentioned it causes most of the deaths. And it can do that really quickly. So a non-immune is somebody who's not had malaria before, maybe born and raised in the US, for example. In a day or two, you can go from well to dead with P. falciparum, the bad form of malaria. So this is why it's so important to try to prevent it in the first place, or if travelers become sick, to get to medical attention quickly, with a fever especially. About half of the world lives in at-risk malaria areas, and as you can see, it's a huge problem globally with 1 million people dying every year. And I just wanted to show you this. This is a really nice map of where malaria is. So basically, it's in the tropics, but the darker areas are the most highly endemic parts of the world for malaria. So especially tropical or Central and West Africa has the most malaria. And Southeast Asia and Oceania also has quite a lot of malaria. Although there is malaria in Latin America, especially in the Amazon and some of Central America, it's quite a bit less, orders of magnitude less than in Africa or even in Asia. This is actually a nice little chart of how likely are you to get malaria if you travel and don't take prophylaxis. So this is if you traveled for a month to this region of the world and didn't take prophylaxis to Oceania, this is Papua New Guinea or the Solomon Islands, 1 in 17. Because there's quite a lot, although the type of malaria there is vivax, which is less severe, there's a lot of malaria there. Then if you take West Africa, where it's mostly falciparum, which is the deadly form of malaria, 1 in 40. So that's a pretty big risk. If somebody traveled to West Africa for a month and didn't take prophylaxis, it's a 1 in 40 chance of getting a life-threatening infectious disease. So this is why it's so important to identify this ahead of time and take preventative medicine so that patients are not put into the situation of being really sick in a remote or resource-poor area. Malaria, when patients do get sick, the one thing about the incubation period is it's not less than a week. So if anybody gets sick less than a week after arriving somewhere, it's not malaria, unless you got malaria somewhere else. But it's usually about somewhere between a week and a month is how long it takes to get sick after being bitten by the mosquito. And how malaria, usually it just causes fever, but it can also cause severe shaking chills, and even diarrhea and cough, but most commonly a fever is what people think of with malaria. So I'm talking about malaria mainly from the perspective of how to prevent it from the travel clinic perspective. So the drugs we use, and there are 4 or 5 commonly used drugs, depend on where a traveler is going in terms of the risk of resistance for the bad form of malaria, falciparum, and the resistance to chloroquine and mefloquine, the most commonly used drugs. So chloroquine is a drug that was developed a few decades ago. It was a synthetically derived drug. It's really well tolerated and was really effective, but because it was used kind of willy-nilly and everybody took it without it being controlled, resistance developed very quickly. And within a couple of decades, we lost chloroquine for the treatment of P. falciparum in most of the world. And now there are only a few parts of the world left where you can use chloroquine. So where we can use chloroquine, we want to use it because it's a safe, well-tolerated drug. But where you can't use it, you have to choose other alternatives. So at the end of all that, what I'm saying is, if a traveler is going to an area where there's only chloroquine-sensitive P. falciparum, then they get chloroquine. If they're going somewhere else, then they get something else. So the areas you can use chloroquine are the light pink areas here, basically Central America and a small focus here in Paraguay, Argentina. The rest of the Amazon and the southern part of Panama is considered resistant, and basically almost the entire eastern hemisphere is chloroquine resistant, except for a few foci in the Middle East here. So all of the dark red here, we would choose a drug other than chloroquine as prophylaxis for patients. And then after chloroquine, there was another drug called mefloquine, which many of you may have heard of. It's also known as Lariam, which was developed later and looked good for about a decade, but we're already losing mefloquine to resistance. You can see the resistance map in just 10 years or maybe 6 years jumped from being just here at the Thai, Cambodian, and Burmese borders to much more of Southeast Asia. So we can use mefloquine everywhere else in the world except for these parts of Southeast Asia, lots of Thailand, Cambodia, Vietnam, Burma, and a little bit of China. So the drugs we use So most travelers are traveling to chloroquine-resistant areas because that's most of the world. Are the top three drugs here usually Malarone, mefloquine, or doxycycline. Malarone is this combination drug called atovaquone and proguanil generically. We wouldn't use mefloquine in the areas I mentioned in Southeast Asia. Doxycycline we can use most of the time. And then there's a drug called primaquine, which is used uncommonly, but more in the last few years. All of these drugs are very effective if taken correctly. And again, that's a big if, because I mentioned that about 50-60% of people take correctly, but the rest don't. So if taken correctly, I'd say 95 to 98, 99% protective efficacy, meaning even if exposed to malaria, they will prevent malaria from occurring. But if taken incorrectly, obviously that goes down a lot. So the differences between these drugs and which drug we select depends on the dosing regimen and convenience, which I'll show on this slide, cost, and side effects, because they're all pretty much equally effective. And I usually go over these with a patient and say, what do you want to do? Because they're all effective. What do you think you would prefer? So Malarone is a daily drug. Mefloquine is weekly, and doxycycline is daily. So one thing is, does a patient want to take a drug daily or weekly? What are you more likely to remember, or what do you prefer? Another is Malarone only has to be taken for 1 week after leaving an endemic area to prevent the incubating form of malaria from coming on later. Whereas the other two drugs, mefloquine and doxy, have to be taken for a month after leaving. So Malarone makes a lot more sense for short trips. If someone is traveling for only 1 week, look at mefloquine, you have to take for like a month and a half for a 1 week trip. But Malarone you would only have to take for about a week and a half. So I usually particularly recommend Malarone for short trips because of how long you have to take these other drugs after leaving an endemic area. And then among the side effects, Malarone is probably the best tolerated with just a little bit of nausea. Doxycycline causes sensitivity to the sun, like sunburn is common. So that's an issue because everybody who's taking these drugs is going somewhere tropical by definition. It also can cause some GI symptoms like nausea or abdominal pain. Mefloquine is kind of famous for its side effects. People get intense dreams, and people who have psychiatric histories probably shouldn't take mefloquine because it can exacerbate depression or exacerbate bipolar disorder and that kind of thing. But I think mefloquine has a bad rap. Like, people think it's worse than it really is. But this is one reason we tell people to start taking this drug at least a week or two before leaving, so we can find out if they develop the side effect before they actually leave. Chloroquine, so I skipped this slide. If someone's going to a chloroquine-sensitive area, chloroquine is also a weekly drug that you take for a month after returning home. So if it can be taken, we usually like to give chloroquine. Sorry, wrong way. Chloroquine is also pretty well tolerated as far as side effects. And then I don't have a slide on this, but cost-wise, Malarone is the most expensive option. So it's probably the best option in terms of, the best tolerated and shortest course after you come home, but it's quite expensive. Mefloquine is probably middle of the road expensive-wise, and doxycycline is cheap, and chloroquine is also pretty cheap. So that can be a factor, obviously, too, for which one is chosen. And then in certain cases, like if a patient's traveling to a very remote area and won't have access to medical care or is going on a long trip, sometimes we give presumptive treatment courses. Usually I choose this drug, Coartem. So that's, if a patient gets a fever, can't present to medical attention for whatever reason, we tell them to start taking this, because I'd rather a patient do that than die of falciparum malaria while trying to figure out how to get to some place where there's actually medical care. That's not done that commonly, but we also do this from time to time too. Okay, so that's it for malaria. So I'll move on to immunizations. I'm not going to cover all possible immunizations, but the main ones that we do in travel clinic. And these 4 are kind of more in the routine immunization category, although we always do address them in travel clinic. But tetanus, diphtheria, pertussis is the top one. Most commonly, it's just tetanus, diphtheria. So you should be up to date on that, have had a shot in at least the last 10 years, maybe the last 5 if you're going to be doing a lot of things that put you at risk, but usually it's 10. MMR is measles, mumps, rubella. So in the United States, if a patient was born before 1957, they're considered immune, even without doing anything more, because measles was so common then. This was before the vaccination campaign. For patients born after 1957, they're supposed to have had 2 lifetime doses. Some patients only had 1 because it was more common in the earlier years of the immunization program to only give 1. So if someone's had only 1 MMR, we often will recommend a booster, a one-time lifetime booster as an adult if that has not been done. Influenza, we think about here in the US as an October through April kind of illness, but if you're going to the tropics, influenza happens year-round. If you're going on a cruise ship, influenza happens year-round. So for many travelers, no matter what time of year it is, we think about influenza. And hepatitis B isn't something that everybody has to have. It's actually a universal vaccine now for infants, but certain situations like for healthcare workers or exposure to blood or those kinds of things, because that's how hepatitis B is transmitted, we'll address that vaccine too. And then one other kind of routine vaccine is polio. Most patients in the U.S. that we see in clinics have had the childhood polio series, but we do recommend that in patients traveling to parts of the Eastern Hemisphere, and I say that because actually polio has now been considered eradicated from the Western Hemisphere. And I think polio is going to be eradicated, period, in the next decade or two, which would be great. It'll be the second disease for that, which that's the case after smallpox. But anyway, in the Eastern Hemisphere, for some countries, we recommend a booster dose of polio because immunity does wane, and there is some circulating polio in a few countries. So this is a one-time, lifetime booster. If a patient has ever had a polio shot as an adult, they don't need another one. And then once they've had that one, they're done. And it's the injectable form or the inactivated form of polio. We do not give the oral form, which is live, anymore because the risks of the live vaccine, which is very rarely the vaccine strain can disseminate, are considered too high. So we just give the inactivated injectable form now. And there's a list of which specific countries this is recommended for. This gets updated every 6 months or a year. So this is nothing for everybody to remember, but we just wanted you to know that this exists, and we look at it. One example that's an important recent change is that India was on this list even last year, and India has gone from one of the 4 countries left in the world where it was considered to be endemic for polio, meaning polio is currently circulating in that country, to now that's off that list, and there's only 3 left now. And it was removed from the list of where you even need to get a booster for imported polio. So it's only about 30 or 40 countries. All of them are in Asia or Africa. Okay, so the rest of the vaccines are more specific to travel. Hepatitis A, I'll start with, and just have a few slides on each of these. Hepatitis A, by the way, is now a routine childhood immunization. So younger patients that we see may have had the vaccine series as a child and are probably done. Most adults, though, that's not the case because that only started happening in the last 10, 15 years or maybe 20 years at most in some places. Hepatitis A is a form of hepatitis that's self-limited, which means it gets better even without any treatment. It causes jaundice, abdominal pain, vomiting. It makes people feel pretty darn sick, like they can't get out of bed for quite a long time. So it's a bad illness to get in terms of being really sick. It's not something that kills you or causes chronic disease, but it's still pretty bad. And it's transmitted by the fecal-oral route, meaning contaminated food and water, contaminated with other people's stool, unfortunately, like all these fecal-oral diseases. So basically, it's endemic to the entire developing world. So this is a vaccine that almost all travelers to the developing world should have. All of the dark green areas here are considered high prevalence, and the light middle shaded area is intermediate prevalence in Eastern Europe and Russia. But basically, all travelers, unless they're only going to North America or Western Europe or Australia, should probably have this vaccine. So, and this is a relatively common illness. It's the second most common vaccine preventable illness that we see in travelers, second after influenza. The risk is pretty high, 3 in 1,000 per month, so that's 0.3% per month. That's pretty high when you think about the number of travelers. Peace Corps volunteers are an example of a population of patients at higher risk because they're in more rural settings and whatnot. So it can be as high as 20 per 1,000 per month in those patients. The vaccine is a 2-dose series over 6 months, so the first dose and then the second dose is 6 months later. But the great thing about this vaccine is you have near perfect protective immunity after the first dose. And that's really great for us in travel clinic because we often see last-minute travelers. And if we had to wait 6 months, people would not be protected. So the question that comes up a lot is for the last-minute traveler is getting that first dose, which after you've had long enough to develop your immune response to that vaccine, is that one dose enough? And it turns out that we think in most cases it is. We used to give immune globulin, which is what IVIG is, to travelers who were going to be leaving in a month or less. But there's a pretty good study. This is an example of one study that shows that even after 2 weeks, over 80% of patients were protected. And at 19 days, it was like over 90%. So unless a traveler is truly last minute and immediately going to be in a risky area, we more commonly will just give them the vaccine and say, be as careful as you can initially during your trip when you're a little bit less protected against hepatitis A. So that's hepatitis A. Meningococcal meningitis, I just have a couple of slides on this. So this is a bad form of bacterial meningitis. Bacterial meningitis is a syndrome where you have fever, headache, neck stiffness. and it can be, significantly 5 to 10% of the time, it can be fatal. So it's very important to prevent that, and that's even with appropriate antibiotics. So it's a very important disease to prevent. This is also being given more commonly routinely now, which is a change from even 10 years ago. So like college students on entry or school-age children are getting this now. But we specifically recommend it for travelers, for those going to the meningitis belt of Africa. So this is Sahelian Africa. The Sahel is the area, the dry area between the Sahara and true tropical sub-Saharan Africa down here. So this meningitis belt has outbreaks all the time during the dry season, which is December through June. So during that season, to travelers here and to other parts of Africa, frankly, too, we recommend this vaccine. It's also a required vaccine to enter Saudi Arabia during the Hajj. And if you've ever wondered why that is, I think this picture kind of shows why, because there's very, very close quarters and a lot of outbreaks occur because of that. So Saudi Arabia does require this vaccine for entry during the Hajj. Anyway, it's a really good new vaccine, the conjugate vaccine, which is basically a better way of giving a vaccine, getting a better immune response. This type of vaccine is approved for age 2 to 55. There's another vaccine for other age groups, and we boost every 5 years if you're going back to a risky situation like perhaps traveling to the meningitis belt in Africa. Japanese encephalitis is another vaccine we think about for travelers basically only to Asia. So this is a form of encephalitis. Encephalitis is a syndrome where you basically get inflammation of your brain, which is a really bad thing to have happen. It causes neurological weakness, numbness, altered mental status, and it's fatal in a significant percentage of the people who get it. Most of East, South, and Southeast Asia is endemic for Japanese encephalitis. Despite its name, it's not only in Japan, so it's in a lot of China, India, all of Southeast Asia, and a lot of Oceania. And it's most endemic during the mosquito. It's transmitted by mosquitoes, so it's mostly during the monsoon and post-monsoon season, which in this part of the world is in the summer and the fall. That's when the most mosquitoes are present. So if patients get symptomatic, although most patients who get infected with this disease don't actually even have any symptoms, as you can see here, but of those who get symptomatic, up to a third die. So, and basically there's no treatment for Japanese encephalitis, so prevention is the only thing we can do. It's really present mostly in rural areas because that's where the mosquitoes are most present. The mosquitoes do really well in like rice paddies, rice fields where there's flooded water, and that's perfect breeding grounds for mosquitoes. And the animals that amplify this virus are pigs and ducks, and they're present in rural areas. So the risk to the casual traveler, like the traveler to Asia who's going for a week or two and staying in capital cities and maybe not even during the transmission season, is very low, less than 1 in a million. But for patients going to endemic rural areas or maybe going to be outside a lot more, especially during the transmission season, it can be many, many orders of magnitude higher, like maybe up to 1 in 20,000 instead of 1 in a million. There have been only a handful of cases reported in travelers, but still there are definitely a lot of cases in children, especially of endemic areas. It definitely is a real risk. So we do think this is an important vaccine to consider despite the rarity of it in travelers. There's a new vaccine for this. There used to be an older vaccine called JEVax. So Ixiaro, it's not important to remember that name, but it's nice because this vaccine is only a 2-dose series instead of the 3-dose series that used to exist, and it has less side effects than the old vaccine. So it's a pretty good vaccine. And who we give it to are long-term travelers during the transmission season, so like, again, summer or fall in most countries. A month or more is what we use for cutoff for long-term. Short-term travelers if they're going to be outdoor a lot or in very rural areas, or if they're going to an area where there's an outbreak. But we don't recommend it for short-term travelers to cities or even to places where it's more rural, but if they're outside the transmission season. So this vaccine is a good example of why it's nice to have the expertise of a travel clinic who makes decisions about when to give this vaccine a lot, because I'm sure primary care providers do a great job with it, but if you only give this vaccine every now and then, and it is a vaccine that most providers only give every now and then, it's kind of hard to know who should get this vaccine and who shouldn't. And I think it's an important one to consider because it gives a lot of peace of mind to travelers, and it prevents a very serious illness if someone were to acquire it. Rabies is it's kind of more of an optional vaccine for most patients. And I don't have a slide on this, so before I forget to mention it, I'll just say now, one reason a lot of people don't get this vaccine is it's a very expensive vaccine. It's $200 per dose, and it's 3 doses, so it's $600 in most, that differs from clinic to clinic, but it's a pretty expensive undertaking. But rabies is an important thing to think about too, because this is a viral disease transmitted by animal bites or contact with animals. If left unchecked, it also causes eventually encephalitis. And it's basically 100% fatal if you get symptomatic disease. There have now been 3 cases of survivors in the last 10 years, but basically it's 100% fatal. So the only thing we can do for rabies is prevent it. And it's 3 doses over a 1-month time period, as you can see here, for prevention. So who should get this vaccine is also kind of a hard question, where it's nice to have someone who has experience giving this vaccine. Officially, it's recommended for high-risk travelers, like if you're going to be around animals, veterinarians, wildlife workers, medical workers, if you're going to be working in hospitals. And then also prolonged rural exposure, because you're going to be in areas where there's no health care if you get a bite, or if you're going to be around animals a lot. And in the US, the most common animals we think about are bats and wild animals, because dogs and cats get vaccinated. But in the developing world, the big risk is dogs. And anywhere you go, you can see dogs and get bitten by a dog. So I think for like a traveler traveling on a trip for a month or more, even if they're not going to be very rural or they don't think they're going to be around animals, you can run around dogs anywhere. And if you get a bite by a dog in a developing country, you kind of have to assume they're rabid, just to be safe. Because again, if you get rabies, it's fatal. So the only way to do it is to assume that they're rabid and then go through the post-exposure prophylaxis, which is getting a vaccine and immune globulin. So here's why I think that vaccine is such an important thing to consider. Oh, by the way, one thing we always counsel patients too is that it's very important to clean any bite wound thoroughly. That's probably about as important as this other stuff we do. That prevents transmission in many cases by itself. Anyway, if you get let's say you get a dog bite, if you've been vaccinated before, you only need to get 2. We still recommend getting a booster vaccine, 2 doses after the bite, and then that's it though. You don't need immune globulin. If you've never been vaccinated against rabies, you need 4 to 5 doses of the vaccine over a 2 to 4 week period, and you need rabies immune globulin, which is a pooled antibody generated specifically against rabies. This is really hard to find in the developing world. It often means that you need to get medically evacuated to a developed country, like the nearest regional, like say you're in Asia, that might be Singapore. You might need to get medically evacuated from wherever you are to Singapore, find this immune globulin, and complete this intense vaccine series of 4 doses. For a lot of people, that means your trip is over. So the peace of mind, right? Finding your way to Singapore and getting into a hospital, whatever you were doing, if you don't want to get rabies, you're going to have to do all this. So the big peace of mind that this vaccine offers is if you happen to get scratched or bitten or encounter a dog, you've gone from that circumstance to just having to get a couple doses of vaccine, which is not that hard to find. That may just mean a visit to a local clinic and getting a vaccine, and it's only over a 3-day period. You get dose 1 on day 0 and dose 2 on day 3, and then you're done. So this is a decision we often leave to the patients. There's not really a hard and fast rule, but I think that the things that lead me to say you should get this is long-term travel, being in a rural area, being around animals, that kind of thing. Okay, yellow fever is an important one to think about, because this is it's the one vaccine that throughout the world you can be required to have to enter countries, and it does have some important side effects for everybody to consider. So it's the one that really requires the most thinking, where again I think having a travel clinic go through that is really helpful. So this is a viral disease that's transmitted by this mosquito, Aedes aegypti is the name of it. And it can be anything from a self-limited, like the flu, to have fatal liver failure and a hemorrhagic fever, kind of like Ebola. You can bleed out and bleed to death. So it can be really bad. 20 to 50% of the people who get yellow fever die of it. And it's a short incubation period. And we have no effective treatment. The only thing we can do is give you IV fluids and try our best to support you, but there's no treatment we can give. So prevention is critical for yellow fever. This year, there was a really big change in the yellow fever map. This is where yellow fever exists. It's only in South America and sub-Saharan Africa. There's no yellow fever in Asia. There's no yellow fever in developed countries. So in Latin America, a lot of the parts went from get the vaccine to this hatched area now, which is considered only for super high-risk travelers. Most patients now don't need it. That's a big change. And also, in East Africa, there's been a change. Tanzania, where there's, of sub-Saharan African countries, that's a pretty common place for people to go because of the safari business, has now been changed from you should get the vaccine to generally not recommended. So this year, there has been a significant change in the recommendations about yellow fever. And one other point I want to make about yellow fever before I forget, I think I have a slide to remind myself at the end, but Yeah, so this is the CDC yellow book on like what parts of Brazil you should go to get yellow fever. So we used to just look at this map and say, oh, Brazil is yellow. You need to get yellow fever vaccine. But again, this is an important vaccine to think about. Do you really need to get the vaccine? So there is very good provincial level data. Like these are the districts where it's endemic, or from that program I showed you before, there's a nice map of exactly where yellow fever is. So just going to Brazil alone does not mean somebody needs to get this vaccine. If they're staying in Rio and Sao Paulo where there's not any yellow fever, they don't need to get this vaccine. So it's very important for every traveler, for us as your provider, to look at where exactly you're going and what the risk of yellow fever is to help with this decision of whether you need it. Anyway, all that being said, here's where yellow fever is in Africa, West and Central Africa. This is the approximate risk of getting yellow fever for travelers that would be unvaccinated and in these areas for 1 month. So the risk is about 10 times higher in Africa than it is in South America. And the risk is as high as 1 in 1,000 if you're going to, say, a forested area of West Africa. That's pretty darn high, 0.1%. It's less than this if you're going to cities and you're not going to be in a high-risk area, but it's still pretty high. 1 in 10,000 in South America, and assuming a 20% case fatality rate, these are the risk of dying of yellow fever in the same situation. As I mentioned, this is the only, by international law, this is the only vaccine that can be required at border entry points in order to enter countries, other than meningococcus for the Hajj, as I mentioned in Saudi Arabia. This is a live virus vaccine, so that's a very important consideration because people with suppressed immune systems, it can disseminate. It's rare, but it can disseminate, and we have to think about that. And the revaccination interval is every 10 years. So what we do is fill out this yellow card that says you got yellow fever. We stamp it with our stamp that says we're a certified yellow fever center. We sign it, and you take that with you, and that's valid for 10 years. At that point, you need to have another vaccine and another card in order to travel. And this is not valid until 10 days after you get the vaccine because that's how long the immunity needs to begin to form after you get the vaccine. So because it's a live virus vaccine, there are several contraindications to getting it. Anybody who's got a suppressed immune system, that can be AIDS and HIV. That could be an organ transplant patient who's on immunosuppressive therapy, a patient with a rheumatological condition who's on immunosuppressive therapy, cancer chemotherapy, etc. All of those things, we would not recommend this vaccine. The thymus is a gland in your mediastinum, in the area near your heart, that helps the immune system generate lymphocytes, the kind of thing that protects against viral diseases. So in retrospect, we found that a lot of people who didn't do well with the vaccine had thymus disease. That could be because they've had radiation because of lymphoma, or they just had underlying thymus disease. So we always ask about that. And young children shouldn't get this vaccine because they don't do well with the vaccine, or egg allergy. Pregnant women and lactating women probably shouldn't get it, although that's considered a relative contraindication, so it's a precaution. And people over 60, it's not an absolute contraindication either, but this always involves an important risk-benefit discussion, in my opinion, because the risks of the bad things that happen with the vaccine are 2- and 3-fold higher for patients over 60 and especially in patients over 70. So this vaccine has a relatively common mild reaction profile. About 10 to 30% get fever or headache or muscle aches, which is what myalgias are. And that's a little more than with most vaccines. About 2 in 100,000 get immediate hypersensitivity, which can be fatal. So that can mean throat swelling, trouble breathing, collapse. So that's rare, but it's something we have to think about. And neurological disease can be anything from meningitis to like developing paralysis and weakness. So that's in about 1 in 100,000. And that risk is 2 times higher, so about 1.5 in 100,000 for 60-year-olds and older, and about 3-fold higher, so about 2 to 3 in 100,000 in 70-year-olds and older. And then on top of all that, there's vaccine-associated viscerotropic disease, which is a fancy way of saying that the live attenuated means weakened. So that just means that the live weakened virus disseminated and is essentially causing yellow fever in the vaccine recipient. This is an extremely rare thing, but there have now been about 40 or 50 cases reported in the world in the last decade and a half or 2 decades. So we are seeing this now. And when it happens, like natural yellow fever, it's got up to a 50% fatality rate. So this is all of the patients who have had this happen have been people getting their first shot of yellow fever. The boosters, it's never happened with them because they probably have some immunity. And it's, in retrospect, some of them had had thymus disease. So we're very careful about who gets this vaccine because of this risk. The risk is only 0.4 in 100,000, but it's 2-fold higher if you're over 60 and 3-fold higher if you're over 70. So if you put all that together, what I do when I'm talking to a patient about yellow fever vaccine is I go through all these rare risks. You know, there's a rare risk of anaphylactic reaction, rare risk of neurological disease, rare risk of this. And then I go through, well, okay, this is the risk of getting yellow fever. And on balance, I usually recommend getting this vaccine. I mean, if somebody is, healthy, no contraindications, and going to a place where there's yellow fever, usually we recommend getting the vaccine. But I do think that these are important, serious side effects that everybody has to think about and make the decision about whether they want to get it. If you don't get the vaccine, you can be denied entry into a country that requires entry. We can give you a medical contraindication to vaccination certificate, which usually helps and greases the wheels, but you could still be theoretically denied entry or told that you have to have the vaccine or you're not going to be allowed entry or quarantined. That's rare. I don't think I've had anybody have that happen to them, but in theory it's possible that it could happen. You could also be quarantined on arrival back to the U.S. I've never heard of that happening either, but in theory it is possible that that could happen to somebody because you're coming from a yellow fever area. The U.S. doesn't want you to bring it back here. Okay, so the last few minutes I'm going to talk about typhoid and a couple of other diseases. Enteric fever refers to typhoid, which is a form of salmonella. It's fecal-oral transmission like hepatitis A, so contaminated food and water. And like hepatitis A, it's basically endemic to the entire developing world. And the hotbed of typhoid is in South Asia, so especially India, but also Nepal, Pakistan, Bangladesh. That's where there's the most typhoid in the world. But really, travelers to pretty much anywhere in the developing world should get the typhoid vaccination. Typhoid causes a basic, a fever syndrome with constipation, abdominal pain, and rarely it can cause these complications, bleeding of the gastrointestinal tract, or even really severely perforation or encephalopathy. That's rare, but it can be fatal when that happens. So we can treat this with antibiotics. It's not as bad as some of the other things I was saying, but it's still an important disease to prevent. And there are two vaccination options for typhoid. There's an oral option, which is a live vaccine, and an injectable option, which is not live. It's a killed vaccine. So the live vaccine is, I like it a little better for two reasons. The revaccination interval is 5 years instead of every 2 years for the injectable, and it has some cross protection against one form of paratyphoid fever, which is a closely related bacteria that causes a closely related illness. So if possible, I think this is slightly preferred. It also means you don't have to get another shot, which I think is nice. But you do have to refrigerate this vaccine because it's a live bacteria, and you have to take 4 doses, so 1 pill every other day for 8 days. So if patients for some reason think they won't be able to do that, or they're traveling very soon, then that might not be the preferred option. The injectable is a single dose. You get it, you're done, that's it. It's revaccination interval though every 2 years. Now this is not a great vaccine. It only protects 50 to 80%. That's way less than most of the other things we've been talking about. So we always counsel people getting this vaccine, you got to still be careful about what you eat and drink because this vaccine is not by any means 100% effective. The risks of the vaccine, it's pretty safe. We would not give the oral vaccine to immunocompromised patients along the same lines as I was talking about with yellow fever because it could disseminate theoretically. We don't know the safety very well in pregnant women, although sometimes they get it, but usually we don't. And they can cause GI symptoms like nausea and vomiting. One other thing about the oral vaccine is because it is a live bacteria, you cannot be on any antibiotics because the antibiotics might kill the vaccine, and then your immune system is not going to be able to react to it, right? And that even includes antimalarial. So sometimes patients start taking their mefloquine 2 weeks before they're going to leave. You can't do the oral typhoid at that point because it does have some activity and might inhibit your immune response. So then we give the injectable. And then traveler's diarrhea, there's no vaccine for this. So this is moving gears from all the vaccines I was going to talk about. Just a couple slides on traveler's diarrhea. I wish we had a vaccine for this because this is one of the most, if not the most common out of all the things I've been talking about of what travelers get. Most forms of traveler's diarrhea are bacterial. This is different than what we see in the US where most diarrheal illnesses are viral. And viral illnesses just tend to get better on their own after a couple of days and are not usually that severe. But bacterial illnesses can be a little bit more severe, and that's usually what causes traveler's diarrhea. Don't let this happen to you, so this is an example of what could happen. Sorry, I don't know how that slide got in there. So this is where traveler's diarrhea is endemic. Like typhoid and hepatitis A, basically the whole developing world, the red part is the most highly endemic, so tropical, developing world. And in the highest risk area, the red areas here, A 2-week traveler has a risk up to 30 to 50% of getting at least a couple of days of traveler's diarrhea. So that is really common. What can you do to prevent traveler's diarrhea? So the first thing is safe food and water. I went over that, so I won't harp on it again. Another thing that's talked about a lot is bismuth or Pepto-Bismol. This is not even an antibiotic, which is nice, so it doesn't have a lot of the risks of inducing resistance to antibiotics and whatnot. This can decrease the attack rate in some studies by up to 2/3. That's pretty good. Antibiotics are even better. So Cipro, which is a common antibiotic, maybe even up to 85 to 90% protective efficacy. That's really good. But we don't typically recommend that travelers take prophylaxis, especially Cipro or antibiotics. The practice of that is waning because really we found that self-treatment is safe. Self-treatment means you take antibiotics with you, and then if you get sick, you treat yourself. That's safe and has basically similar outcomes to taking preventative antibiotics. And taking preventative antibiotics is expensive and just is going to generate a lot more antibiotic resistance, which is a big problem that we face these days. So we only really recommend doing this in certain circumstances, like maybe a traveler who's got a huge presentation and they can't get sick, and it's really, or immunocompromised patients, or for those, the lower ones, the lower 4 here, are for those for whom if they got diarrhea, it would be really bad. They could get sick, like ostomy patients or inflammatory bowel disease patients. They might get really sick if they even got a mild form of diarrhea. So this is the groups where we might recommend it, but otherwise we usually don't. So what I usually do is I recommend giving most patients to the developing world a self-treatment course. A lot of patients are used to having Cipro. Cipro does work in a lot of the world. In Asia, though, one of the most common bacteria is called Campylobacter. You can see the resistance rates are sky high, even up to nearly 100% in Thailand. So we don't recommend Cipro very commonly anymore to Asia. Even in Africa, we are beginning to see more resistance to Cipro, although not as much. So more commonly, I'm giving this drug now called azithromycin, which is a drug used often for pneumonia and respiratory infections, but it's pretty darn good. Most studies show as good as Cipro. So for Asia and some other parts of the world too, I'm giving azithro these days too. There's another drug called rifaximin that's given to some patients, but azithro is more common. So we're almost out of time, so I just have a slide or two on other infections. These are things that you can't prevent as much, but just wanted you to know about them because they're things we see in post-travel ill patients and other things you can get. Dengue is a really important one to know about because this is very common, and it's another mosquito-borne illness. This is the same mosquito that transmits yellow fever, Aedes aegypti. It's a viral illness that's transmitted by this mosquito. This mosquito, by the way, has a completely different epidemiology than the Anopheline mosquitoes that transmit malaria. This likes living in cities and bites during the day. That's the opposite of Anopheline. So we usually see more dengue in cities than in the countryside, which is the opposite of malaria. There is no vaccine, unfortunately, for dengue. So all you can do to prevent dengue is try to avoid getting bitten by a mosquito. So use your DEET, right? Don't rely on malaria prophylaxis because there are other things. So this usually causes fever, muscle aches, joint aches, and if it gets more severe, low platelets, and that therefore cause a propensity to bleeding. And there's a severe form that is rare, but this is the big concern with dengue, is that a minority, like less than 1% of patients, but still 1% of patients can get hemorrhagic fever or shock syndrome, which can be fatal up to 10% of the time. And we only can do supportive care. There's no effective antiviral for dengue. Schistosomiasis is a parasitic infection transmitted in fresh water. This goes right through intact skin. You don't need to have a cut, or it doesn't need to be a mucosal surface like your mouth. It goes right through your skin. So in an endemic area, like basically all of Africa, I usually recommend against swimming in lakes, rivers, or streams because of the risk of schistosomiasis. What this causes, so if you don't want to get schistosomiasis, you shouldn't do this because there's really nothing else you can do to prevent it but not go in fresh water. And what this causes is basically rash early on. It can cause a febrile syndrome that can be severe about a month or two later, but that usually goes away. But chronic schisto means liver disease. It can cause, if you get a lot of re-exposure over and over again, it can cause fibrosis of your liver and some bad complications in the genitourinary system too. It's rare for that to happen in travelers, but still, it's something you probably want to avoid. This is where schistosomiasis is endemic. Basically, all of Africa. Only a few countries in the Western Hemisphere. Central America is safe, but there are Caribbean islands, and then Brazil, Venezuela, and remember it's Suriname or French Guiana is endemic. And then there's a fair bit of Asia that's endemic too. And there's a couple others, just one slide each. This is becoming more common in travelers to southern Africa, like safari trips to South Africa or Zimbabwe or that area. African tick bite fever is a rickettsial illness. It causes an eschar, which is this, a dark spot at the site of the tick bite, and then fever, lymphadenopathy, rash. It's usually self-limited and can be treated with antibiotics, doxycycline, but avoiding tick bites is how to avoid getting this. And leptospirosis is another disease that's transmitted by fresh water. It's a bacterial infection. This does usually need to go through a mucosal surface like the mouth or eyes or a cut, and it can lead to another febrile syndrome, fever, headaches, muscle aches. Rarely it can cause a severe syndrome that can be fatal, but most patients get a mild illness, and it can be treated with antibiotics. But this is another reason to consider whether to swim in fresh water in endemic areas. Okay, so travel medicine is a very difficult specialty that we work very hard at, as is tropical medicine. So this is the end of my talk. So I just wanted to summarize. So good preventative measures, first of all, the general things I mentioned at first. And then in a travel clinic, you should always make sure you've thought about vaccinations, most of the vaccines I mentioned, malaria prophylaxis, and traveler's diarrhea. And then tropical medicine, which is more the ill-returned traveler. Fever is the most common syndrome we see, and the big three things we think about with fever are malaria, dengue, and typhoid, the most important of which is malaria, because remember, malaria, you can go from well to dead in a couple of days. And then gastrointestinal illnesses like diarrhea most commonly, or skin things, we see a lot of those things too in our clinic. So our clinic can see all these illnesses too. So just a last slide and a plug. Again, we opened 3 weeks ago and are now seeing patients. There are 3 of us. Dr. Berry and myself have certifications in tropical medicine, and our nurse practitioner, Nanette, who is terrific at travel medicine. This is our phone number and our website. And one thing that's kind of unique about our clinic is we have expertise both in the pre-travel aspect and the post-travel aspect. Most clinics do only one or the other. So that's one thing we like a lot about our clinic. So here's our website and our phone number. So please come and see us or tell all your friends about us. And I think that's all I have. Yep. Thanks a lot for your time. So I think questions. Yeah, please. The malaria medicines? Yeah. So you're asking about the expensive. There's things that are expensive. One was I was talking about the rabies vaccine, which was like $600. So that is very expensive. Among the malaria medicines, I was talking about mefloquine, malarone, and doxycycline. So malarone is the one that's very expensive. We're talking about a cost of like, so here are the options for, other than chloroquine. So if you're going to a chloroquine scenario, here are the options. The top 3 are the most common. So doxycycline, say for a month, it would probably be like $5, $10, $15, $20 at most. Mefloquine, per pill, mefloquine is very expensive. It's like $7, $8 per pill, but you only have to take it once a week. So for a 1-month trip, it's probably $50, $75. Malarone for a month trip, now it's per pill less expensive than mefloquine, but you'd have to take about 40 pills of malarone for a 1-month trip. So that would be probably, I don't know, $100 to $200 or so. It's more expensive than mefloquine, but it's not like orders of magnitude. It's probably like 2-3-fold. The big difference is if you're going for a long trip, because you have to take it every day, malarone becomes more, increasingly more expensive, whereas mefloquine is weekly, so they become closer together. For a short trip, that's where I think the cost difference is less, because mefloquine you only have to take it for a week after coming home.
Those are all still pretty cheap as opposed to the expensive.
That's true. Compared to getting malaria and being hospitalized, this is very cheap. Yes. Sure. And actually, let me answer a corollary point too, which is when to come to travel clinic. It's great. It's best for patients to come 1 month or more, because many vaccines require, like I was saying with hepatitis A, at least 2 weeks, but a month ideally for the immunity to develop. You can come with less time, but a month or more is ideal. So if it's going to be a long trip, there are 2 things about a long trip. One is, let's say it's a Peace Corps volunteer going away for 2 years. A lot of those patients will choose not to take malaria prophylaxis, even if they're going to a malaria endemic area, because they worry that the side effects of 2 years of medicines is a lot more. And that's a choice that some people make, and they take presumptive treatment with them, but don't take prophylaxis. But I think that's another issue about there, is I would be more likely to recommend the rabies vaccine, or things, because they're going to be away so long. Pre-travel, though, there's no need to stagger the vaccines. You can get all of your shots at the same time. What you can't do is, the rule of thumb is you can't get live virus vaccines. So you have to get live virus vaccines either all on the same day or at least 1 month apart or more. So as long as you get them all on the same day. So this would be like yellow fever is a live virus vaccine. MMR, measles, mumps, rubella, is another live virus vaccine. I didn't mention varicella, chickenpox. That's the one I should have probably mentioned because it's more of a routine one. But anyway, that's a live virus vaccine. If you get them all on the same day, it's okay. But if you get one and then you think a week later, I want to get varicella too, you have to wait a month before getting it. And then the other thing is Japanese encephalitis, or let's say rabies, because that's a live virus vaccine. Rabies, there are 3 doses actually. So you can get them at the scheduled interval, which is 0 days, 7 days, and one month later. But you can't get anything else in that time period. You'd have to wait until that 1 month is over to get them apart. So basically, timing the vaccines is either all together or a month apart or more. Did you have a question too?
Yeah, I had a question. On my last 2 trips, I had traveler's diarrhea that persisted for a couple weeks after I got back.
Yeah.
And I just was kind of curious about it. Well, one thing is, what are the implications of letting your body fight it off versus running to the doctor and getting back antibiotics? Because does it impart any resistance if you fight it off? And the other thing is, I'm curious, when you mentioned Pepto-Bismol, using it to protect you, how you do that?
So the second question is a quicker answer, so I'll answer first. It's just taking a dose of Pepto-Bismol every day. And the main side effects are getting a black tongue, a little bit of constipation. Black tongue, but it's nothing serious. It just looks bad.
How does it work?
Oh, it's because it basically it binds things that the bacteria need to replicate and makes the environment unfavorable for them. So your first question was, does getting treated for traveler's diarrhea, does that help you later or not, or does it impart resistance? So there's not much. So many things cause traveler's diarrhea that I don't think getting infected with one of them is that likely to prevent you from getting traveler's diarrhea in the future. So there's not that much protective immunity. Getting treated is not likely to abut an immune response that would help you later. On the other side, another corollary of that question might be, does getting treated mean you are less likely to get a month of symptoms later on? And the answer is no, it probably doesn't. The only caveat to that is if you get protozoal or parasitic diarrhea, that is typically longer lasting. So when people have diarrhea for longer, that's the one I have here. Long-term travelers are more likely to get it. And this is where, because most bacterial diarrhea, even without treatment, will resolve within a week or two. If people have had diarrhea for a month or more, I'm worried that it's not that they have untreated bacterial, it's that they have a parasitic. That's a completely different type of antibiotic. So that's why it's important to remember that. One last thing about that is we see a fair number of patients who have had traveler's diarrhea who have very persistent symptoms, where they last for like months or even a year or more. And it becomes like an irritable bowel-like syndrome where they have alternating diarrhea and constipation. And frankly, we don't really understand why that happens. And we don't have a good way of predicting in whom that will happen and in whom it won't. It probably happens because either the bowel flora, meaning the normal commensal bacteria that live in your colon, have been permanently altered as a result of getting this bad bug you got. It might mean that your immune response, that your way of recognizing self from not self has changed, or it might mean that there is something persistent that we just aren't picking up sometimes. Who knows? It's probably one of those 3 things, and we don't really have a lot of good treatment options, but most of the time it's not because there's something that if we treated it, it would get better. It's that they just have this persistent syndrome. 2 weeks or so is not like what I'm talking about. This is something that's much more persistent, but it is something we see a lot.
Is it inadvisable to let it go a month?
To let symptoms go a month? Yeah, I would probably recommend somebody be seen if their symptoms last more than a week or 2.
Any issues about rotavirus and Norwalk, like on cruise ships?
Yes.
Things like that? Any recommendations on prophylaxis versus treatment after the fact?
Good question. So norovirus and rotavirus are 2 very common foodborne viral causes of diarrhea. In the developing world, rotavirus is one of the most common causes of severe diarrhea in young children. There is now a rotavirus vaccine, by the way, available in the U.S. for children. There was an older vaccine that was taken off the market because it caused a bad side effect called intussusception. And norovirus is very common. It's probably one of the most common causes of diarrhea, even in the U.S. It causes a short episode. It causes both vomiting and diarrhea. And as you mentioned, cruise ships in particular have outbreaks of norovirus especially. Rotavirus less so, but norovirus in particular. For norovirus, there is no vaccine and no preventative measure other than safe food and water. And if you're on a cruise ship, there's not much you can do other than eat the food the cruise ship provides. So I guess all you can do is hope that your cruise ship is doing a good job, and don't eat whatever everybody else that just got sick ate. And there's no treatment either. So the treatment of norovirus is symptomatic therapy, rehydration, and whatnot. For rotavirus, there is a vaccine, but it's not currently licensed for adults, and we don't recommend it. It's not a travel recommended vaccine. It's more something we see again in children, really, especially in the developing world. Although we do see it in children in the U.S. now too. So with rotavirus, similarly, these are both fecally, orally transmitted. So it's basically just clean food and water as best you can to prevent it.
One other question is that on pregnant women, for those who are adventurous to travel, any specific guidelines on vaccines like live versus or live attenuated versus killed vaccines?
Well, yes, I think that is most germane to yellow fever. So as I mentioned, that's a whole important discussion to have. It's a relative contraindication for a pregnant woman to get the yellow fever vaccine. It's not an absolute contraindication, but I would be personally, as a provider, really nervous giving that vaccine to a pregnant woman. I would probably advise the woman not to travel to where she's going, or I would say, well, here's the risk of getting yellow fever if you don't get the vaccine at all. Pregnant women are, as we all are, of course. I don't mean to, genderify, but we all think of an unborn child, and we're very protective of them. So I find that most patients like that don't want to take risks like putting something in their body. So it's uncommon that a pregnant woman comes to the clinic and says, I really want the vaccine. More commonly than not, they would either choose not to travel or to not get it and take a medical waiver with them and see what happens. The other vaccines like varicella, MMR, I would probably recommend deferring those vaccines until after pregnancy. I don't think they're considered, for the most part, recommendations are not to give them during pregnancy. So I would say defer.
And maybe one more question, if I may. There's a total solar eclipse going over Queensland, which is northern Australia, in November, which is their summer of this year. I'm not going, but many people I'm sure are going. And I noticed that Japanese encephalitis is endemic to the very northern tip of the Queensland Peninsula, and of course that area is close to New Guinea, which so it probably shares some of its infectious disease ecosystem. Should people going to Australia, get the Japanese encephalitis vaccine?
I have to look it up. I think the answer is yes, but don't quote me on that, because for yellow fever, for Japanese encephalitis recommendations at that level of detail, I usually look in the yellow book and in Travax to see. But I think the answer is yes, because as you said, the very northern part of Australia basically shares the infectious diseases epidemiology of Oceania. And I'm pretty sure that Japanese encephalitis is endemic. Assuming it's endemic there, that time of year it would be recommended because that's post-monsoon when there's a lot of mosquitoes. But I would look that up before I would make that recommendation on the yellow book and in the Travax program. Sure.
Yeah, just for, say, Indonesia and, say, Northern Australia, Darwin, what recommendations would you make for that?
In terms
of Java, if you were to get into Bondiac, this type of thing. As a general traveler, not as
general traveler.
Going out.
By the way, if Queensland's is here, then this is in the endemic zone. So you're just saying, what would you recommend for a traveler to Indonesia in terms of generally speaking? So Asia, there's no yellow fever. I would for almost every traveler to the developing world, I'd recommend hepatitis A and typhoid. So if somebody has not had those vaccines, those two for sure. I would go through the rabies risk-benefit discussion I just had, depending on how long they're going to be there, where they're going to be, what their risk-benefit profile is for that. Japanese encephalitis, there's definitely a lot of Japanese encephalitis in Indonesia. So assuming they're there in the transmission season, I would probably, unless it was a brief trip, like a week or less, I might not recommend that. But most travelers, I would probably recommend that. So somebody going to Jakarta only for a week, probably not. Somebody going to rural Indonesia for a month, I would. Somewhere in the middle, it would be a risk-benefit discussion. Probably would be going to a malaria area. I don't think there's malaria in Jakarta, but in the rural parts of Indonesia, there is definitely malaria. So we would go through what malaria prophylaxis is necessary. Probably recommend azithromycin for traveler's diarrhea, for presumptive treatment if the patient got ill. And then a lot of those general recommendations I mentioned.
Thank you.
Sure.
Okay, I am not supposed to take any live vaccines whatsoever because I have a very bad immune system. Where can I go? Home?
You
Just,
can go.
I mean, Europe.
Yeah, you can go to
Western Europe.
No, as far as the
Canada.
you can definitely go to the developed world, right? Canada, Western Europe, Australia, New Zealand, Japan, Israel. Those are considered developed world. North America, Canada, but developing world. Well, Turkey's Eastern Europe kind of epidemiology, so it's a little bit different. But developing world-wise, you couldn't go. So you couldn't get the yellow fever vaccine.
Mm-hmm.
So that wipes out tropical South America and the middle of Africa. You could go to South Africa actually, but you couldn't go to the yellow fever parts of Africa. See, there's no yellow fever in southern Africa or northern Africa, but this belt in the middle, and you couldn't go to this yellow area here. But outside of that, you wouldn't need yellow fever. And the other vaccines are not really live. You know, Japanese encephalitis, rabies are not live vaccines. Typhoid, you would get the injectable instead of the oral, so that's not live. You could get that vaccine. Even the polio booster is not live. You know, it's killed. So you couldn't get MMR, you couldn't get varicella, you couldn't get yellow fever, but you could get most of the other stuff.
Okay, thank you.
Sure.
How about Hep B vaccine?
Hep B is a good one to have for in general, you know, because once you get hepatitis B, a certain percentage of people get chronic hepatitis B and you're at risk for cirrhosis then. It's now a routine vaccine. Hope everything's okay there. It's now a routine vaccine, so we're giving it to all of our children. But for adults, we don't feel like everybody needs to have it. We recommend it if you're going to be around blood in healthcare settings. But so that means like a lab worker working in a hospital, tattoo parlor, you know, that kind of thing. It is transmitted sexually. You know, hepatitis B is transmitted sexually. As a healthcare worker, you know, for the people I've of course been vaccinated. All healthcare workers should be vaccinated for hepatitis B. But for the general population, it's a 3-vaccine series over 6 months. You don't necessarily have to have it, but it's a very safe vaccine. It's not a live vaccine. I think it's just a good idea to have, but overall, the risk of it's not that high that we recommend that everybody get it.
So I'm going to Turkey in May 17th. Should I come see you tomorrow?
That's coming up soon, yeah. Turkey. So Turkey would be hepatitis A and typhoid would be the big vaccines. Probably not going to be in a malaria endemic area. I don't think there's much malaria in Turkey. There's a couple small foci, but not much malaria.
So I had Hep A 10 years ago,
You're,
and typhoid probably.
yeah. Hepatitis A, the key is that you've had both vaccines, because it's the second vaccine that gives you persistent immunity. So if you've had both vaccines, we don't even recommend testing you or anything. We just consider you immune. Typhoid, you may need, that's something that would be nice to have a booster if it's been more than 2 years or 5 years, depending on which one you got.
That's different from the
Tetanus, yeah. Tetanus you should have if it's been 10 years or more. But those would be the biggies for Turkey. Sure. Yep, great. Well, thanks very much for your attention. Appreciate it.